Let's take a quick look at some of the skeletal muscle relaxants that are on the market. Our focus here will be briefly to explain the agents used as skeletal muscle relaxants in the management of treating various muscle spasticity conditions. This chart is a pretty succinct review of the differences between spasticity and spasms, and important for us to recognize because the agents we choose in each of these are different, and so we want to pick the appropriate agent for the appropriate condition. When we think of spasticity, typically at least I'm thinking of a centrally based process, which is a disorder of the upper motor neurons. Presents typically with stiffness, hypertonicity, and hyperreflexive states. And typically this is the type of spastic condition that's seen with multiple sclerosis, with cerebral palsy, with spinal cord injury or traumatic brain injury, those kind of conditions. And the agents we use to treat this variable, but most often the agents that I've historically seen in practice for such conditions are baclofen and diazepam, perhaps dantrolene and a few other agents that are listed here, including under certain circumstances botulinum toxin. Spasms are, however, are differentiated. Typically we think of spasms as related to a skeletal muscular pain or injury of some kind, mechanical back injury, for example, also seen with fibromyalgia or sciatic nerve pain or neurogenic pathogenicity as well. And the agents that we typically will see occasionally used here for back pain are some of the agents listed here include carfentanil and methocarbamol, among others. And we'll talk about some of the ones that we'll see used in a couple of slides. The next set of slides we'll focus on primarily come from the Utah Medicaid Pharmacy and Therapeutics Committee from a couple of years ago. And they really did a nice summary review of the evidence that supports and refutes the basis for the use of these agents and where they really fit in practice. So I'll try to sort of outline some of the key concepts. But if you look at the drugs that are on the market here, the base drugs that have chosen as skeletal muscle relaxants that are available on the market really came on the market years and years ago, decades ago, with some of them in the late 50s and early 1960s, and really moving maybe through the early 80s when baclofen was approved. The most recent agent, Xanaflex, was approved in 1996. But most of the agents in this category were put on the market or brought to the market when the FDA did not require quite as much evidence to support their clinical efficacy and safety. And so many of these agents have pretty much grandfathered in. And what we'll see is that many of these agents don't have the strong level of evidence that we would hope to see in clinical practice before using a drug. So the summary in this document that's posted online, and you can sort of link to the full document if you'd like, is pretty elegant actually, in that it reviews in their executive summary a number of key points that clinicians might want to think about as far as what the evidence to support these agents' use is in practice. Chemically, the agents that are on the market, these older agents, differ in their chemical structures and pretty much how they're working. In addition, there aren't really any clinical practice guidelines that would recommend any of these agents for first-line therapy for treating pain or spasm. And so we see them used on a case-by-case basis, sometimes short-term, sometimes longer-term. And I think the only issues that we'll see is that when you have a situation of spasticity where you've got a central pathology involved, we see baclofen maybe with dantrolene or tenazidine considered second-line agents in those conditions. And even then, the data is not elegant, it's not superb, but it's there. The efficacy of these agents, unfortunately, most of the trials that were done in the 1960s and 70s, weren't particularly great studies. And since these agents are all available generically now, there's not a financial interest for pharmaceutical industry to spend the millions of dollars in evaluating the efficacy of these agents. So we're relying on really poor designed or fairly or poor designed studies from decades and decades ago. So keep in mind that the efficacy of these agents for treating muscle pain and spasm appear to decline over time, and there isn't really any advantage, particularly in acute peripheral muscle spasms, that they offer. These agents offer any real advantage over the classic nonsteroidals when it's appropriate to use those agents. The adverse effects for these agents, they're often problematic for a lot of patients. Some of these agents include a lot of antimuscarinic or anticholinergic side effects. They also can cause some significant sedation, falls risk, particularly in older population, and hepatotoxicity for some of these agents is also a problem. So their summary data really look at limiting the use of these agents for treating muscle pain and muscle spasm, and when they're used, short-term use for peripheral indications, and for a central indication to really evaluate before and after once you start therapy, and periodically during therapy evaluating the risk-benefit of using these agents. The remaining slides, which there are a number of them, are tables that differentiate each of these agents on a number of different things. First of all, here's an overall comparison of the agents used first for spasticity, but we'll look at the agents where they fit in practice, their dosage form, their labeled indication use, and some other considerations for them. And baclofen and dantrolene, really for spasticity with a central origin, do make sense for these limited circumstances where the spasms are really problematic. And we will see some of these agents used longer term. In fact, baclofen, to avoid some of the more significant side effects and to manage spasticity more consistently throughout the day, there have been over the last decade or two the availability of an intrathecal pump where baclofen is loaded into the reservoir of that pump and is used for patients with significant muscle spasms, either MS or CP or something like that, when the spasms are really problematic. Dantrolene also can be used for muscle spasms. The other issue for dantrolene is it is considered the quote-unquote antidote for perhaps neuroleptic malignant syndrome, but malignant hyperthermia that sometimes is associated with muscle rigidity with the use of anesthesia. The other agents for spasticity listed here, I won't go through them specifically, but you could sort of look at where they fit and what some of the idiosyncrasies of these agents are. And yet more data for some of these different agents and how they differentiate themselves for management of muscle spasticity. Finally, there are also some combination products that I think most clinicians really try to avoid and really pinpoint a clear role for these. And all of these agents, typically most clinicians would see as short-term treatment for muscle spasm that's associated with usually some sort of a traumatic, a localized lower back pain trauma, and evaluating the risk and the benefit. The data for clinical practice guidelines for the use of these agents is somewhat lacking. And as you see, where most of these agents fit is for the adjunct of pain management after nonsteroidals or other therapies, acetaminophen, when it makes sense that you need to add something and you're weighing the risk and the benefit. In practice, I think we may see sometimes these agents used in patients who have a history of opioid habituation, for example, you want to avoid opioids, But keep in mind that even these agents have some potential for habituation in some patients, even though many of them aren't control drugs, that patients may have more difficulty once they start on these agents to come off of them, perhaps with some modest kind of withdrawal symptoms that patients may see, and or some change in their response to therapy. More data on some summary guidelines, particularly related to very specific kinds of conditions like shoulder pain or patients who have traumatic brain injury. Finally, more issues in multiple sclerosis, for example. They can sometimes be used for treatment of spasticity. Baclofen is considered, of all of the agents, probably the agent where there's a little more data for it, and so it makes sense to consider using it. And then some other conditions listed here as well. Their third chart looks at some pharmacokinetic variables for each of these agents. If you're interested, you can look at this in the next chart for some of that summary information. More summary data on pharmacokinetics. And then some dosing recommendations related to special populations, particularly patients who have renal or hepatic impairment, issues in pediatric patients, some issues for pregnancy category risks in the older terminology, the ABCDX terminology, use in patients who are women who are lactating or breastfeeding, and some considerations in older patients as well. Again, more data for all of these. And I think you'll find that, particularly in older patients, many of these agents are associated with significant sedation and or falls risk and are generally avoided. The safety profile of these agents is listed in the next two slides from this chart. They did a great job with this. And you'll see those kind of conditions where greater than 10% of the patients who are on these drugs will have some issues associated with their use. And what you'll often find is that patients will often have some constellation of central nervous system somnolence, dizziness, which may or may not improve over time, but certainly are issues, for example, for driving a car or managing or operating with dangerous equipment and the like. Yet more data for safety of these agents and some of the more common side effects that are noted. Again, most of the time we see dizziness, sedation, somnolence, something like that. And then the final few charts look at some comparative efficacy studies when there have been trials in some of these agents, either spasticity or musculoskeletal conditions. And I encourage you to look at the column about the levels of evidence for which most of the data is either poor or only fair, that they're not great data for these agents. And so that's one of the reasons why clinicians really reserve these agents for refractory cases where first-line interventions aren't as effective. More data on comparative safety of these agents for both spasticity and skeletal muscle conditions, with a concern for the agents for spasticity with hepatotoxicity being a concern, particularly with dantrolene therapy. The next chart here are some of the clinical evidence for skeletal muscle relaxants systematically. And again, some of the data here is somewhat limited. You could look through it and find any benefit that you may see from reviewing this data. But most clinicians sort of, again, steer away from these agents unless there's a compelling indication. And finally, use in pediatrics is usually going to be limited to children, for example, with significant cerebral palsy and significant spasms associated with that. We would not, in general, consider these agents appropriate to use in pediatrics unless there were a compelling indication such as that. Okay, I hope this little brief review is helpful.